Assalamualaikum doctors. In this video I am discussing about precocious puberty. So precocious puberty, that is starting puberty before the age of 9 years. Remember, in boys early puberty is pathological and girls late puberty is pathological. So boys early puberty is pathological, girls late puberty is pathological. Precocious puberty comes as a history. We know hypothalamus is secret the gonadotropin releasing hormone, and pituitary gland and gonadotropin. Okay, these control the sexual development and reproduction. So there is a pituitary or gonadal axis, any problem occur that time. What are the problem list in precocious puberty? We can keep. First of all, precocious puberty tumor, capulate patches and increase in head size. One is neurofibromatosis, remember. So history main concerns is precocious puberty. How can we take? When, how started, in the form of what tempo of puberty in order, what then what. Okay, what is the first event? Is it isolated or precocious? In boys, if testis, ask if unilateral or bilateral enlargement. What about the weight, height, head circumference and appetite? Does she look like you or his daddy? When you got first menses and her daddy start shaving, is there any morning headache, morning vomiting? Is there any concern about the double vision, hearing and smell? Then general FWSL, fever, weight, activity, sleep, any other concern, any chronic conditions. Again I am telling chief complaint analysis, what are the questions we ask. First of all, what is the main concern? So it is precocious puberty. When started, how started, in the form of what tempo of puberty, in order to what then what. Okay, full explanation we take. What is the first event? Is it isolated or precocious? In boys, if testis, ask if unilateral or bilateral enlargement. What about the weight, height, head circumference and appetite? Does he look like you and his daddy? When he got first menses and his daddy start shaving, is there any morning headache, morning vomiting? Is there concern about double vision, hearing and smell? Hearing and smell. Then we go the fever, weight, activity, sleep, any other concern, any chronic condition. Systemic review one by one. First of all, CNS, signs of increased intracranial tensions, abnormal movement, fears, weakness in any part of the body, abnormal behavior. CVS, any fainting attack, awareness of heartbeat, chest pain and blood pressure. Respiratory system difficulty, breathing issue if obese, snoring sound, recurrent bugs, pillow used for sleep. GIT, any change in the bowel habit, tummy size, tummy pains, stria on abdomen and its color. Urinary, any concern about pee and bed waiting. MSK, about the skin discolorations, acne, excess hair in the face, freckles in private or axilla, skin spots, hypo or hyperpigmented, sergeant number, bone, pain, lumps in the body. So MSK is very important. I am again repeating. Skin discolorations, acne, excess hair in face, freckles in private or axilla. Freckles in private or axilla are the features of neurofibromatosis. Skin spots, hypo, hyperpigmented, sergeant number. If the patient is telling yes, there is capillate spot, then we can ask what is the sergeant number. Any bone pain, lump in the body. Endocrine, prefer any weather. Hematology, bleeding from any side, pallor, bruises, recurrent bugs. Past history 5 TIOA, that is any chronic conditions, treatment, complications, team, operation, transfusion, investigations, admission, travel, trauma to the head, any drugs. Perinatal, natal and postnatal history, nutrition and vaccination and allergy history, development growth chart if present, family, social and impact, school type, attendance, performance, relation to his friends. What is the differential diagnosis of precocious puberty? When it come on the history, we first keep ready. First of all, true synchronous, that is follow the tempo, it is intracranial. And pseudo asynchronous, that is non-follow the tempo, extracranial. So true is the intracranial, like any idiopathic, trauma, tumor, hemorrhage, hydrocephalus syndrome, neurofibromatosis, primary hypothyroidism or prolonged untreated primary hypothyroidism, septo-optic dysplasia, cerebral palsy. Drugs are OCP, street drugs, and gym. Again, what is the true or intracranial cause? First of all, idiopathic trauma, tumor, hemorrhage, hydrocephalus. These are we size. That's why we ask head size, because hydrocephalus, trauma, tumor. Then nephrotic syndrome, neurofibromatosis. Sorry, neurofibromatosis features we exclude primary hypothyroidism or prolonged untreated primary hypothyroidism. Septo-optic dysplasia, cerebral palsy, drugs are OCP, street drugs in gym. Now pseudo. What are the pseudo? Extracranial. These are not follow the tempo. Okay. First of all, adrenal, we find Cushing syndrome, congenital adrenal hyperplasia and tumor. So Cushing syndrome feature we know, obese tria there is, and also Cushing syndrome there is a steroid taken history can be present. Congenital adrenal hyperplasia, they can be tell that sodium low, blood pressure low. In history we can find plus precocious puberty. Maybe the investigation finding the tell. Any tumor. Gonadal or ovarian tumor, ovarian cyst, testicular tumor, McCune-Bright syndrome, ectopic or hepatoblastoma, dysgerminoma, excess hormone. So this is the DD of precocious puberty. If complete analysis, I am again telling when first started the precocious puberty, when you notice in which tempo one by one details we take, what about the head size, any unusual feature, dysmorphic features, skin conditions. Father mother puberty we ask when started. Child has a vision problem, hearing problems, abnormal movements, morning headache and morning vomiting, very important because tumor associated with that. Child weight, height and appetite. These are if testis enlargement, is it unilateral or bilateral?